Namaskar, friends. Today, I'm going to discuss a patient of diabetes mellitus who has established cardiovascular disease. We'll take the case of one person, AB, who is a 53-year-old corporate executive, and he was diagnosed with diabetes 6 months back when he came for a routine checkup complaining of generalized weakness. His family history was positive for high blood pressure and myocardial infarction. As a risk factor, he was a heavy smoker for the last 30 years, but he quit 5 years back and has been trying to lead a healthier lifestyle. In addition, he had a previous myocardial infarction 3 years back. When we examined him, we found that he's obese. He had a weight of 92 kg with a height of 5.8 inches, giving him a body mass index of 30.7, which is obese. And his blood pressure was 140/90. Rest of the examination was normal. In his evaluation for the blood investigations, he had uncontrolled diabetes with a hemoglobin A1C of 8.4%, which should be less than 7% in any diabetic patient. He had a high low density lipoprotein, which is a risk factor for cardiovascular disease, that is 137, which should be less than 70 in cases of diabetic patients. And the good cholesterol, that is HDL, was low, it was 37, and slightly high triglycerides of 156. Kidney function tests were normal with the eGFR of 65 ml per minute, but the urinary albumin creatinine ratio was 50. On drug history, he was taking just metformin 1 gram twice daily after food for his diabetes. For his blood pressure, he had been prescribed telmisartan 40 milligram once daily, along with amlodipine 5 milligram once daily. For cholesterol, he was taking atorvastatin 10 milligram once daily, and he had a dual antiplatelet drugs, aspirin 75 milligram daily and clopidogrel 75 milligram daily. Now, when we look like these patients, we need to manage them considering their cardiovascular protection as to protect from their further myocardial infarction or coronary artery disease or heart failure, for their macrovascular protection, both for nephropathy, retinopathy, and neuropathy. He requires weight reduction because he was obese, and to reach their glycemic goal of hemoglobin A1C of less than 7%, but without incurring any hypoglycemia event. And the dose schedule should be convenient so that he can follow it completely. So the primary consideration in this case is cardioprotection and to optimize glycemic control for cardiovascular risk reduction and to address any weight issue. So we added a combination of SGLT2 inhibitor along with a DPP4 inhibitor, and which has very benefits both for cardio and renal protection. It is a simple regime. It has an early and durable efficacy, achieving the glycemic goal of reaching less than 7% and causing loss of more than 1% hemoglobin A1C. In addition, it also leads to weight loss and low blood pressure, slightly decrease in the blood pressure, and very minimal chances of hypoglycemia. Friends, as you know, that cardiovascular disease is the leading cause of morbidity and mortality in adult patients with type 2 diabetes, with especially if the onset of these complications tend to occur 12 to 15 years in patients of diabetics as compared to the general population. The excess risk of this atherosclerotic cardiovascular disease in patients with type 2 diabetes has been estimated to be at least twice that of those without diabetes. In Framingham offspring study in USA, looking at 1,945 patients, suggested that two-thirds of the patients of diabetes have subclinical cardiovascular disease. Subclinical, that they do not have any symptoms of cardiovascular disease in spite of that suffering from a cardiovascular disease. And diabetes increases the risk of subclinical cardiovascular disease by 4.34%, which is very significant p-value. And this subclinical cardiovascular disease increases the risk of cardiovascular event by more than twofold. The vascular wall in patients with diabetes is well known to have an advanced atherosclerosis. When very important study that was EMPA-HEART in 2015 that affects empagliflozin on cardiac structure, function, and circulatory markers in patients with type 2 diabetes showed that empagliflozin resulted in early and significant reduction of the left ventricular mass, leading to regression as detected by cardiac MRI imaging. And it also suggested it lead to a reverse cardiac modeling, which may be a possible contributor to the cardioprotection effect of the SGLT2 inhibitors. In 2015, the era of evolving dimension of cardiovascular care in type 2 diabetes management began with the EMPA-REG outcome study, which demonstrated significant benefits of empagliflozin for cardiovascular mortality by a very significant margin of 38%. All cardiovascular events, as well as 3-point MACE, that the major adverse cardiovascular events in type 2 diabetes and cardiovascular disease, all were reduced. All types of cardiovascular deaths were reduced with empagliflozin, and more prominent absolute benefits were observed for heart failure-related disease and even sudden cardiac death. The post-hoc analysis of EMPA-REG demonstrated consistent cardiovascular mortality benefits irrespective of prior cardiovascular events, whether the patient had prior MI or a stroke, whether patient having an underlying heart failure burden or no burden, whatever the levels of CKD level or the normal kidney function, baseline hemoglobin A1C, control of the multiple cardiovascular risk factors, or a background use of drugs like metformin. Several mechanisms have been proposed for CV effect of SGLT2 inhibitors, including osmotic diuresis and natriuresis, leading to blood pressure lowering, decrease in arterial stiffness, and decrease in uric acid and oxidative stress. It has also been reported that SGLT2 inhibitors promote reverse cardiac remodeling, improve myocardial energetics and filling conditions, reduce left ventricular wall stress and mass, and reduce blood pressure and arterial stiffness. The EMPA-HEART CardioLink 6 study demonstrated that empagliflozin could produce early reverse cardiac remodeling in type 2 diabetes patients with stable coronary artery disease. In Carmelina and the Carolina trials, DPP4 inhibitor linagliptin was used, which also demonstrated cardiovascular and renal safety, which were the secondary endpoint with linagliptin in this study of linagliptin versus placebo or a active comparator when added to the standard care in patients with type 2 diabetes who were at high risk of vascular complications. So this EMPA-LINA combination is available as first-in-class treatment with SGLT2 inhibitor and a DPP4 inhibitor combination group of drugs. At week 24, this combination of EMPA-LINA with a 25 and 5 milligram combination showed statistically significant hemoglobin A1C reduction, that is less than minus 1.08, baseline of 7.99% added to metformin, and hemoglobin A1C decrements for EMPA-LINA combination demonstrated more than 1.81% hemoglobin A1 reduction when the hemoglobin baseline AVC was more than 8.5% at 24 weeks. The combination offers a suitable component and strategy to achieve target hemoglobin A1C without hypoglycemia and weight gain in patients with high baseline hemoglobin A1C level, together with the cardioprotective benefits in these patients. So we have a significant cardio-renal protection with this combination. Thank you.